Good morning, ladies and gentlemen. It's my great pleasure to address you as part of this conference on a topic which will be critical for the future months and years in regards to the situation of intravenous drug users and the most vulnerable in our society. I gave myself the title of Fentanyl intoxication or system failure, which sounds pretty dramatic because I think the topic is really dramatic. And these are potentially two perspectives and two alternatives on how to read the current situation, but there may be more, and we will find out. And I try to discuss and explain the current evidence as best as I can in order to start the conversation, not in order to finish it. So my name is Michael Krausz. That's a very interesting picture. And my conflict of interest is that I'm very much of the opinion that research needs to serve and research needs to contribute to the improvement of the caring for the people we need to care for. For my work, I got research from different agencies, including the Canadian Institute of Health Research, World Health Organization, UNICEF, CCSA, Mental Health Commission of Canada, Coast Mental Health, Bell Let's Talk, and others. I have several functions in the mental health care system, sitting on several advisory and editorial boards internationally. My academic affiliations are with UBC and with Charité Berlin. I'm a leadership chair for addiction research, and that's it for me on this presentation. I want to start the conversation with a discussion I had with my students around the overdose situation. And they were kind of really disappointed that so little is discussed in schools, including medical school, that the attention and the situation for overdose victims is not even close to what we hear as daily news from the COVID-19 pandemic. But most people say it's not my problem and it's a user's choice. They don't need to use. And also, if you really compare the reporting about the risk of mortality for COVID patients to the risk of mortality among overdose patients, it's surprising how little is reported by Canadian media. It's silence, more or less. And the healthcare system also, to a large degree, is blaming the victims. So the question is, why is that? And how is it possible to, and I really think a lot how to discuss that with the next generation of experts. So I start with my personal experience. My personal experience, and a very significant part of that, was in the late 80s and early 90s in Central Europe, where there was overwhelming and shocking open drug scene. And I was very impressed by the contrast of extreme poverty and violence in the drug scenes in the middle of the most beautiful environment you can imagine in Europe, in the open drug scene in Zurich at that case. And it was very interesting to me how the Swiss society, as a structural conservative society, responded to the HIV crisis, to the level of drug overdose and suicide in their society, with one of the best healthcare systems in the world. And they responded with a real commitment to change and consensus in societies. There were several public votes in favor of a change in drug policy and in support of heroin-assisted treatment, for instance, which is a highly controversial area in North America and still not regulated as it should be. And important for my career choice was the outstanding and most important role of research in resolving that crisis. It was a door opener for new interventions and for changing the overall approach to the situation. So this is how Platz Spitz in Zurich looked before and how it looked during the 90s. And it's quite a contrast. And my learnings from these open drug scenes were you need public support to address a public health crisis. So that was proven in Switzerland by several votes in favor of a new drug policy, the necessary resources, new intervention, and new strategies. And to be very clear, they were proven to be right and appropriate. The HIV numbers dropped, and good substitution treatment is still the most effective measure to decrease the incidence rates among HIV. And the research, again, can be a critical tool to provide transparency and clinical guidance, and it is a necessary part of change. Or if it's not doing that, it's useless. So that leads me to another question. So what I call the crisis dilemma. The current situation is as bad as in the beginning of the HIV pandemic. And we know it took over 15 years for an effective response to HIV in Central Europe as well as in the rest of the world. For now, we have to acknowledge that the social environment in our country is not supportive and occupied. It's supportive of the drug use and addressing the overdose crisis appropriately, and it's totally occupied by the COVID-19 pandemic. There is a lot of stigma still, and we don't have the necessary system in place we need to build, which we need to build. So, and the crisis dilemma too is that in order to change something, you need to acknowledge it. You need to see it as a reality and not excuse things from happening, but focus on the discussion. What do we need to change? What do we need to innovate? What do we need to do to bring down the numbers? I want to do that in the following 5 topics. And I start with the facts. The facts in British Columbia, as an example, and the situation is even worse in some other parts of North America. We had nearly 6 fatalities per day in the recent months. In the first quarter, we had 680 fatalities, and over 100 were under 29. And fentanyl was nearly involved in all of the cases. So that has to do with a significant shift which needs to be acknowledged and needs to be acted on. There is a significant change in drug markets. Since 2013, we see a broad contamination with fentanyl of street drugs. And since 2019, we see dominance of fentanyl. More and more people, probably the majority of people, are seeking fentanyl. We see a lot of people in the drug scenes would never use just heroin. And I'm really aware of the fact that I say just heroin. If you compare the fentanyl, it's 50 times more potent in terms of, or compared to morphine or to other opiates. And in addition, we see also an significant increase in the use of methamphetamines. So we have a fentanyl dominance, and this is probably the new reality, and we're not prepared for that. If you bear with me for a little while, we tried to bring together the international experience on the overdose crisis. The orange bubbles are countries with a moderate rate of opioid overdose. The blue ones are the high rate overdose, and I show you another picture in a second. And the gray ones are the countries which are doing relatively well. If you look into the left corner, the biggest bubble is the United States, and Canada is right above that. And Lithuania, a European country at the Baltic Sea, these are countries with enormous amount of overdose fatalities and nearly no substitution coverage at all. We have a very low substitution coverage. If you look at the x-axis and you see the most successful country in the upper right, the Netherlands, they are providing nearly complete coverage for substitution or O treatment, and they also providing the y-axis, they are providing harm reduction service, safe injection sites, and all the other necessary things. And you see they don't have an overdose crisis. Switzerland doesn't have an overdose crisis. Austria doesn't have an overdose crisis, and so on and so forth. So what you see is that if a country has a low coverage in substitution or O treatment and is providing very little harm reduction, so safe injection sites are still illegal in large parts of the United States, and harm reduction services are not existing, but especially O treatment is not existent, you see a direct consequence in the number of deaths due to overdose. Let's go to the next picture. If you analyze the current reporting, you see the three clusters, but you see kind of also a continuum between countries. And what you see is that you have a cluster of countries with extremely high, and these are not all countries, but you see the most important one with extremely high numbers of overdose. You see a group of countries with increasing overdose rates, and you see a large number, the majority of countries with no overdose crisis. It's very interesting to compare the experience and their treatment system too, in order to decide, okay, what can we do different to address this awful situation and stop the dying in our countries? So if you look, there are obviously big difference, and one of the biggest and most important learnings is to look what they are doing in order to improve the situation. So we published a paper on that and summarized that. I recommend that closely for reading in Current Opinion of Psychiatry, just published in June. And there was also a big discussion about the role of prescription drugs. What you see here is a curve of the amount of morphine per capita. And the very interesting thing is that there are, for instance, countries in the top group of using especially morphine or whatever for pain treatment. But what you see, there are two countries which have a significant overdose crisis, like Canada and the United States. And there are two countries, or three countries, Switzerland, Austria, and Germany, with a very high level of prescription opiates with no overdose crisis. So it's absolutely important not just to see the amount of prescribed morphine equivalents or opiates, it's also the question, how is the treatment system prepared and how is pain treatment organized in a way so that not people are left alone with their conditions and not getting a proper clinical trajectory. So that is, in very short terms, the evidence we are seeing, and it's going beyond, obviously then, because obviously we are living in a situation, if you look at BC, where the numbers are still rising. We saw last year 1,700 and a bit fatalities, historic high numbers for British Columbia and for Canada, and we will see this year even more. In the first quarter, I just mentioned, if that trajectory is realizing itself, then we will see over 2,000 fatalities in British Columbia alone, with a very relatively small number of citizens. And if you also look at the role of fentanyl, right now this is a plateau since 2017, with over 80% of fentanyl positive toxicology among those patients which were dying based on their injection drug use. That doesn't mean that fentanyl is the only cause, but it means that the fentanyl is a very, very important and significant ingredient to this situation. That led in a few years already to kind of a state of emergency, and the police and the Vancouver mayor and at that point, and others to respond to that. And it was, to be honest, it was not really successful, as we saw in the numbers. There was probably goodwill, but the situation didn't improve since then. So we have a boost also of local fentanyl production. We have a totally different situation in the background, and we don't have a treatment system which is able to cope with that. So the numbers are extremely high, and the COVID-19 pandemic for sure increased the amount of problems to cope with. So what are the dynamics of drug markets, and why am I bringing in this more economic aspect of that? Drug markets and other black markets are functioning based on economic dynamics. And fentanyl is now produced in Canada. It's not imported. Since 2019, there is just an import of precursors, which means substances necessary to create fentanyl. And fentanyl now is produced in North America and in Mexico, which is safer for trafficking, cheaper, and it is universally available. So users more and more switching to fentanyl as a drug of choice with all its consequences. It's no longer an exception, it's a choice, it's a drug of choice, which is a very dangerous path, significantly more dangerous patterns of use. And we don't have an effective prevention about that. Kids are not talking about that, as we saw in the beginning, about fentanyl or overdose, what to do, what are the consequences. Adolescents and young adults are especially neglected in this discourse about awful and very dangerous situations. So they run away if they see something like that, and they don't understand the risk. And the main treatment, opiate agonist treatment, has zero coverage under, or very little coverage under age, so under 18. And people, and a lot of professionals still think that the safest way is to just detox young patients even if they don't wish so, and go for abstinence as a treatment route, which is only working for a very few. The response is a crisis-driven with a lack of continuity and very little interdisciplinary help, as we could show in a lot of publications over the recent months. Okay, fentanyl is a game changer. So the interesting and important question is also talking about use, how to make sure that less kids are dying based on an overdose. We saw in April of this year, the first 12-year-old dying based on a fentanyl overdose, as you could read and or hear from CBC. So, so what shall we do with that situation? How can we protect children and adolescents? So that needs absolutely and clearly said a new system of prevention, a new and non-existing system. It needs to be a topic in schools. Kids need to understand what's going on, and they need direct access to help. It's unacceptable that children, after an overdose, more or less sent back to the environment and back to their social network without the proper supports. And they need to be included in everything which works for adults too, especially including psychosocial care and substitution treatment. Acute care response is only a small part of the response. Otherwise, more people under 29 or under 25 even will not survive that. Again, yeah, that was not so much the situation in the open toxins in Europe, but prevention was always talked about and was initiated in Switzerland at the year. And what they managed as the most important result of all their changes in drug policy was to decrease the incidence of heroin use in Swiss society, which is a very hopeful signal that you can be successful in addressing the high-risk users and addressing the situation like the open toxins in Europe. It can be successful. There are ways to do that, but we didn't find it. And we have a more complicated situation than in the middle of the 90s. What were the key response elements in Canada? Yeah, so there was, the major focus was under the leadership of public health. It was to ramp up the emergency response. We had probably 26,000 emergency calls, nearly 100 calls per day in British Columbia, unheard of numbers, but we still have a very limited in quality and retention treatment with Suboxone as first line of treatment. We have more safe injection capabilities, but it's still not working as it could be and should be. And the BC government initiated something we will discuss also, the safe supply strategy, and giving away high potent psychotropic substances to a non-therapeutic environment. Okay, so how to change that situation and how to understand and interpret the situation? First of all, I want to claim with one critical scientist, Albert Einstein, a very basic learning for every researcher. You cannot solve problems with the same thinking used when they were created. That is so true for medicine too, but it's still an exception. To give you another example, one of the most important debates here in British Columbia over the last 2 decades was how to stop HIV and AIDS. And I was at that time in the 80s and 90s, I was working in a big harbor town in Germany. And it was very interesting that the early initiation of substitution treatment, at that time methadone maintenance, and safe injection and other similar policies, that it was possible to decrease the HIV incidence between 1996 and 2000 to 3.8%. In countries like Spain and Italy and France, which ignored this development and just stayed with a very abstinence-oriented and non-preventative policies, it skyrocketed, and Portugal too at that time. The HIV incidence skyrocketed to 33% of all intravenous drug users, which is mind-blowing. So you see at this map the big impact on the right policies and the right measures on a very threatening development and how much of an impact it had on a public policy international level. You can do it. You can change the trajectory of a catastrophe. So methadone was the single most effective measure to reduce the HIV incidence overall. And I tried to, summarize the effects and counterbalances in this little slide. If the contamination of street drugs is high, as I said in the beginning, over 80% in British Columbia, and if there are high potent opiates involved in street drugs, you don't have control any longer of what you're consuming, and the price is low and the purity is high, the mortality will be extremely threatening. If you are able to improve the quality of care, which means that you are able to provide a care which is actually appreciated by users with high potent opiates and with all kinds of setting and easy access, then you will be able to retain them in treatment, and you will be able to achieve a high coverage. So the mortality will go down. The retention rate in OAT treatment in Switzerland, for instance, is around 70 to 80%. In British Columbia, it's under 30% in the first year of treatment. The problem in Switzerland is the growing age of drug users, and in our country, unfortunately, are high fatalities based on overdose, yeah. Okay, so it's a desperate situation. And if I summarize that, yes, the fentanyl intoxication is definitely a major reason, and the change of drug scenes. And we will discuss that also in our breakout session following. The drug markets are changing, and we have a new normal. We need to accept that. Other substances add to that, sure, but that is the most important one for a new dynamic in the drug market scene. But we also have a system failure, and we knew that before. Access to OAT treatment is below average to other countries. And in international comparison, the retention is extremely low, as I mentioned, and mental health and counseling is often not available, or most of the time, and especially for young people, it is only a small minority of kids we are able to help. Youth is a totally underserved population, and we're doing right now very little to change that. And going back to my students, they say, oh gosh, that is an awful situation. How can we change that? Is there any silver lining we can look for and we can hope for? Okay, yes, I see silver lining, but I also see it on the backdrop of a very, very grim and complicated challenge. I want to give you these 4 examples, and I go through it bit by bit. So the role of the public, the decriminalization, learning from international experiences, the role of research, prevention, a good emergency response, but especially a cohesive trajectory of treatment. Okay, so one short summary statement on the public options. For resolving a public health crisis, you need public support. If the public supports for a healthcare reform and abolishing stigma is getting bigger, you have a different framework. You definitely can do more. You can bring down the numbers, and this is something we shouldn't miss. Talking about prevention. Okay, I'm not in favor of just generic promises. We need to start with a preparation on a population level to manage the risk, improving the likelihood of a good early response, and a collective system of help. For that, we need to integrate prevention into the school system and anywhere in the healthcare system to raise the awareness. The numbers of overdoses for fatalities were double the amount of COVID deaths in the last year. So we need to really think about the question, how can we ramp up our response significantly? So decriminalization is a big discussion, and I heard the mayor saying, yeah, he's all for it. Great. It would stop a downward spiral and make the access to care easier. We need to pave the way to a quality treatment system instead to the prison system. There is still more money spent on enforcement and other things than on treatment. We need to balance that out, and we need to find a good alliance, like in the 4-pillar approach already promoted, and decriminalization should be a part of that. Obviously, there are lots of learnings, and it is critical to study what's going on in other countries. The biggest available source of inspiration in this field is what happened in other countries. I think everything which works should be done in Canada too. Every treatment which is working and effective in other countries should be available and regulated in Canada too. And we should make the comprehensive treatment system the backbone of our response in general. I mentioned research here because I'm working as a researcher. Research can be a critical tool if used for the benefit of patients and not for lame excuses of that why things are not working. They need to work for the benefit of patients and providing evidence for decision makers and system development. If they are not useful, they shouldn't be funded. I think you should hold research as accountable to success and to change and innovation, and also as an independent voice and not as an opportunistic voice, just telling decision makers what they would like to hear. So the emergency response is another important thing. It's a prerequisite, not the solution. It can be an opportunity to start recovery, but that means you need to make treatment really attractive, and people need to feel safe, and it needs to continue immediately after people wake up, which means you need to work with them on resolving problems and addressing their personal situation and their personal misery. Last not least, the only path from my perspective is to resolve this situation is a comprehensive treatment system. And if you want to know more of that, I'm happy to talk about the details. Contact me. I'm happy to provide you with what documentation evidence internationally which works, but we don't have the system we would need. So the take-home message from here is, the question is, are we part of the problem or of the solution? Only if we overcome the related stigma to intravenous drug use, to opiate use, to use of psychotropic substances, if we overcome stigma, we have to own the problem in order to resolve it. We can't expect our children and the next generation is doing that on their own and not with the necessary resources in place. I hope I was able to paint the picture appropriately. This is the beginning of a conversation we need to continue. And I would really be happy if we are able to come up with more synergy, with more determination to end the dying of our most vulnerable in society and stopping this awful development. Thank you very much for your patience and your interest.